Thank you very much for your kind attention, and definitely I would be happy to take any questions, or else I'll request my co-faculties to continue. Anything you want to share? I know I am 30 minutes late. Yeah, then I was stipulated. It happens. What to do? So please, guys, be ready for 9th of September to arrive if we will continue like this speed. What do you say, Dr. Darshan?
Yes, sir. I think so. We should be quick a little, but they're benefiting from the talk actually. So it's good. They're asking a lot of questions. It is a two-way process. It's nice.
Okay.
I think so. If there are no questions, we'll start with the next topic, sir.
Yeah, please continue.
So good evening, everyone. I'm Dr. Darshan. I'm a practicing intensivist from Bangalore. So the topic, the next one which we are starting is hepatic
Darshan,
encephalopathy.
I'm actually leaving because I have to go to the hospital. There are
Sure,
three.
sir. Sure, sure. I'll take it
Okay,
from here.
sorry. Yeah,
Thank you. Thank you, sir. Yes. Sir. So is my slide visible?
Yes, Darshan.
Okay. So going ahead with this. So I think so hepatic encephalopathy is something that all of us are, aware of from our medical school as well as MD days. So how is it different for us in DM is what we need to know. So we need to understand how do we classify, how do we grade, how is it different from an acute event, liver disease causing hepatic encephalopathy, or a chronic liver disease patients ending up with hepatic encephalopathy. So there are a few nuances that we need to understand at this level. And that is what the DNB board wants us to understand in the curriculum they have provided. So going with the outline of the top, we are going to start with the definition and classification. What is hepatic encaph? How do we classify and grade it? What is the pathophysiology? What are the risk factors? How do we diagnose? And how do we manage hepatic encaph? So from the question bank, which was looked into, we found out that these were the three questions which were asked in the recent past. Diagnosis and management of metabolic encephalopathy being the recent one, pathophysiology of hepatic encephalopathy in June 22, and critical appraisal of new medications, treatment strategies, and management of hepatic encephalopathy was asked in FNB. So coming to the definition of hepatic encephalopathy. Hepatic
Darshan,
yes.
sorry, can you put it in a slideshow mode, please?
Yes. Is it visible now?
Yes. Okay.
Okay. Are the slides moving?
Yeah. Yeah.
Okay. So hepatic encephalopathy is a brain dysfunction caused by liver insufficiency and or portosystemic shunts. It has a broad spectrum of neuropsychiatric manifestations, which can range from subtle subclinical alterations to a severe coma. So how do we classify hepatic encephalopathy? It can be either classified based on the severity, like overt or covert or minimal, or based on the pathology or the inciting factor, like type A, which is usually seen in acute liver failure, type B in portosystemic bypass, type C in cirrhosis, and type D in decompensated chronic liver disease. So when did they end up with this classification? There has been a lot of classifications involved. You can remember one or two. The most thing would be based on these four factors. Okay, so going from the left to right, it is classified based on the underlying cause, the severity, the time course, and the precipitating factors. So majorly what we usually come across or need to remember is these, that is underlying cause and severity of manifestations. Time course and precipitating factors is something that we need to understand in the etiology and the occurrence factors. So coming to the classification based on underlying cause, it is classified as ABCD, as I've already mentioned before: acute liver failure, portal systemic bypass, cirrhosis, and acute and chronic liver failure, respectively. Coming to severity of disease manifestation, it is usually classified by International Society of Hepatic Encephalopathy and Nitrogen Balance. That they have divided into, again, two things, that is covert and overt, or it is minimal and other part, that is overt. This is, again, if you see minimal with grade 1, 2, 3, 4 classification, it's similar to WHC, that is the West Haven classification. So coming to the time course, it is again classified based on episodic, recurrent, and persistent. Episodic, here hepatic encephalopathy bouts that are occurring within an interval of more than 6 months. So if anything happens before 6 months, that is, the patient comes and gets admitted with hepatic encephalopathy within 6 months of the previous insult, then it is termed as a recurrent hepatic encaph. And if the patient has persistent behavioral alterations, then it will be classified as persistent hepatic encephalopathy. So if we know a precipitating factor, then it is called it as precipitated hepatic encaph. For example, it can be infection or upper GI bleed, so to say. And if we don't know the precipitating factor, it will be classified as hepatic encephalopathy, non-precipitated. So coming to the definition based on the severity, so there is something called as covert, minimal, or minimal hepatic encephalopathy. Bear in mind, these are two different things. Covert is separate and minimal hepatic encephalopathy is separate. It is a clinical diagnosis and often difficult to diagnose. The difficulty is because in a minimal hepatic encephalopathy, there will be no clinical signs. It is usually diagnosed with the use of neuropsychological or psychometric tests. Whereas covert hepatic encephalopathy, you can usually use the West Haven's classification, and it is usually graded as grade 1. So what is grade 1 and West Haven classification? There will be cognitive or behavioral deterioration, which is seen in these patients. Okay, so this is how we usually classify covert minimal hepatic encephalopathy. So what are the neuropsychological or psychometric tests which are used to diagnose minimal HE? Testing strategies can be divided into psychometric or neuropsychological, the gold standard of which is psychometric hepatic encephalopathy score. So these two things are the broadly classified into psychometric, which is again classified into paper pencil test and computerized, and neurophysiological, usually you can use critical frequency or an EEG. So usually when patients present with this type of hepatic encephalopathy, they will be ward-based patients. So we do not see such patients in the ICU. But having said that, these will help us understand the small subtle changes which the patient can worsen, especially in a case of patient with acute liver failure who might be developing hepatic encaph. So you can do a few paper pencil tests at your bedside evaluation on a daily basis when you have a patient admitted with DCLD or an acute liver failure to understand the onset of hepatic encaph. I will stress on the need of such assessments in the later slides. Hope I'm clear with all of this. Going on to the next slide. There is always a organ crosstalk. Hepatic encephalopathy is nothing but organ crosstalk. It is usually seen because of liver malfunction affecting the brain. So brain dysfunction usually happens in liver failure due to two reasons. Either it is seen in an acute insult which causes acute liver failure. The usual manifestations of brain dysfunction in acute liver failure would either be a cerebral edema, or in the worst case scenario, when the cerebral edema increases, it causes raised intracranial pressures, ends up causing herniation. That is the deadly event. In chronic liver disease, the usual manifestation is encephalopathy. So coming to pathophysiology, before going to pathophysiology, can anyone just unmute and tell me the grades of Asterixis? So just to break the monotony, it's been us talking and you guys being quiet. Can anyone just take in and tell me the grades of Asterixis? Asterixis is usually seen in any type of NCAFs, okay, metabolic NCAFs, so or failures. Yeah, please go ahead. Does anyone want to attempt? So Asterixis again is graded into 4 grades, okay, 0, 1, 2, and 3. So usually the grades are based on number of flaps which occur per 30 seconds. So if there is no flap, that is grade 0, that will be 0 flaps. So based on the number of increasing in flaps, the grading will be 1, 2, and 3. Usually less than 5, then 5 to 10, and more than 10 or 15 usually gets graded as grade 3 Asterixis. So coming to pathophysiology of hepatic encephalopathy in CLD, usually it is the ammonia which is the primary, havoc-causing molecule in the onset of hepatic encephalopathy in patients with CLD. So we all have read this multiple times, I think. So I'm going to go into the smaller subtle nuances, what happens. So basically, whenever there is hepatic encephalopathy, which happens, the problem would be in the liver derangement. So there will be drop in hepatocytes, that is the functional hepatocytes, and there will be drop in molecular pathways, which is going to be over saturated. That is the urea cycle, which is supposed to degrade ammonia, gets affected. So usually all of this leads to an overaccumulation of ammonia, and that causes the transport into the circulation, ends up in the cerebral circulation, crosses the blood-brain barrier, and causes a lot of problems. So usually ammonia is primarily produced in the gut by protein digestion, by bacterial urease activity. So this alteration in any of the intestinal barrier causes bacterial translocation and leads to a systemic inflammation. When the urea cycle is overwhelmed, the capacity to control ammonia gets breached, and hyperammonemia occurs. So once ammonia can cross the blood-brain barrier, it causes problems with glutamine metabolism. So glutamate will be converted to glutamine, and glutamine sets in another series of problems, majorly causing astrocyte swelling. Okay, that causes cerebral edema to start with, and then along with this, there is aquaporin channel activation. Along with aquaporin channel activation, it also causes some neuroexcitatory problems in the brain. So the next one is phosphate blind activated glutaminase. This is actually present way far away from the brain. It is usually in the intestine. Again, PAG catalyzes the hydrolysis of glutamine into ammonia in patients with cirrhosis. But what happens is, if this intestinal concentrations of PAG are higher, it doesn't happen, and glutamine gets accumulated, again causes astrocyte swelling, and it leads to occurrence of hepatic encephalopathy. So this turns into a vicious cycle. So there are two hypotheses when the question about pathophysiology of hepatic encephalopathy is asked. We need to understand and write. That is the ammonia hypothesis being the primarily the most important one. As we all know, ammonia is something that needs to be metabolized. It doesn't get metabolized. So that causes accumulation, and that causes multiple neurotoxic effects. It alters the transit of amino acid. It impairs the amino acid metabolism. It inhibits generation of excitatory and inhibitory post-synaptic potentials. So you need to remember that it does both excitatory and inhibitory issues in the brain. Inflammation is something that gets triggered, and it is an ongoing process. Hepatic encephalopathy is a prolonged inflammatory state in the brain. That is something that we need to understand. One argument against ammonia hypothesis is that even though there is normal serum ammonia levels, you can still see patients having hepatic encephalopathy. So this is the reason why it is still a hypothesis and not an established cause for hepatic encephalopathy. So having said this, ammonia still doesn't cause any classic EEG changes that you can use to diagnose hepatic encephalopathy on an earlier basis. So what other possible hypotheses are there? So there was one more hypothesis which was proposed, that is the GABA hypothesis. What does GABA hypothesis say? GABA is nothing but a neuroinhibitory substance produced in the gastrointestinal tract. Of all the brain nerve endings, around 20 to 45% may be GABAergic. Increased levels of GABA and endogenous benzodiazepines in the plasma usually would permeate into the blood-brain barrier and cause some inhibitory postsynaptic potentials in the brain. That is why you see the fuse slowing, and then the patient becomes lethargic. So the lethargic and the comatose state of the patient in hepatic encephalopathy was explained by the GABA hypothesis. So I will come to these. Actually, there are multiple. Why do you need to know ammonia hypothesis, GABA hypothesis? Is basically because the treatment is based on these approaches. So coming to the risk factors and triggers or the causes for hepatic encephalopathy, it can be ranging from decreased metabolism or clearance of ammonia. It can be because of renal failure, diuretics, transjugular intrahepatic portosystemic shunts, or it can be due to increased production of or absorption of ammonia. So usually when the risk factors or any causes are asked, please divide it classify it and write it. Even if you can write one cause in each, it will be portraying as a better understanding of the concept to the examiner rather than writing it randomly, like in the previous case, like in pancreatitis. So when you classify risk factors, write it as decreased metabolism or clearance, increased production or absorption of ammonia, electrolyte disturbances, respiratory issues, vascular occlusion, and drugs. So what happens in the production or absorption of ammonia is if there is excessive protein intake. There have been multiple studies you usually seen people used to attribute it to animal versus plant-based protein intake, but there has not been any study which can prove one is worse over the other. Okay, so gastrointestinal bleeding, constipation, infection are the causes for increased ammonia production. Electrolyte disturbances, usually metabolic alkalosis and hypokalemia go hand in hand. Any of this can trigger the occurrence of hepatic encephalopathy. This is one of the other things that we need to remember when managing a patient with hepatic encaph, usually in the grade 1 or grade 2. So if we don't look at these smaller things in our daily rounds, this patient might end up in grade 3, grade 4. Respiratory issues like hypoxia, hypercapnia, vascular occlusion like portal vein thrombosis and hepatic vein thrombosis, which are usually seen in patients with chronic liver disease, is something that we need to keep a watch. When most of our things are negative, we need to do an imaging to rule out these causes. Drugs like opiates, benzodiazepines, alcohol, and hypnotics have also been attributed for the cause of hepatic encephalopathy. This usually you can remember as a mnemonic called as hepatics. So hemorrhage, excessive protein intake or potassium, alkalosis, TIPS procedure, infection, constipation, and sedatives. So this is usually the overall major pictorial depiction of risk factors. So there was a canonic study which was done to understand the occurrence of hepatic encephalopathy in decompensated cirrhosis as compared to acute and chronic liver failure. So acute and chronic failure with DCLD will be a separate topic, which we will be discussing later on today. So just to broadly tell you what it is, usually a decompensated cirrhosis mostly involves the liver parameters. The problem decompensation is hepatic, whereas in acute on chronic liver failure, it can be hepatic along with extra hepatic decompensation. So what usually happens is in decompensated cirrhosis, the clinical features which are usually seen are the patients would be usually older cirrhotics. They'll not be active drinkers. That is, they are inactive drinkers. The liver dysfunction probably would be low. So whenever you see the OTPT enzymes, probably will be normal. Minimal inflammatory reaction, the prevalence of organ function or failure would be lower. And because of all these issues, the mortality is also less. The most common issue with these patients developing hepatic encephalopathy in decompensated cirrhosis is the use of diuretics. So we need to stop the diuretics, and probably that itself could help them get better. As compared to this, if you see an acute and chronic liver failure, usually these are young cirrhotics. Okay, usually binge drinkers with very severely altered liver functions, bilirubin crossing 15, 20, increased inflammatory response in SIRS. If you see the SOFA score, it will be sky high, more than 2 or 3, and prevalence of organ failure, like estimated by SOFA, would be high. So because of all these reasons, the mortality is higher in such individuals, and the precipitating factors here would be active alcohol abuse, bacterial infections because of gut translocation, or dyselectrolytemia, most commonly hyponatremia. So how do we manage these patients with hepatic encephalopathy in chronic liver disease? So usually the approach would be to diagnose, treat, and what is the evidence. So you have a patient who comes with a history of CLD, altered mental status, and cirrhosis on your evaluation. How will you proceed? So I'll just stay with me when I'm going with this, so that we finish this busy slide in a quick and a swift way. So if whenever a patient comes with you having these 3 features, that is history of CLD, AMS, and cirrhosis, you have to rule out any possibility of alternate diagnosis. Along with that, you have to also see what is the current activity of daily living for these patients. So going on to the left-hand side, if you stay with me, if you feel that altered mental status is because of any other cause of metabolic encephalopathy, then you should evaluate those causes and treat accordingly. How will you come to a diagnosis? You need to do your basic blood panel, your complete evaluation of clinics, and then obtain other sonological tests to come to a complete diagnosis. If you feel that is not the case, then you need to look on the right hand side. So usually you have to see whether the patient is having a overt or a covert type of hepatic encephalopathy. And is this the first time that he's having hepatic encephalopathy, or is he a case of recurrent or a persistent hepatic encephalopathy? Based on that, we need to go ahead and plan our four-pronged approach. So initially, you have to get the complete history, rule out alternative etiologies, identify the precipitating factor, and correct the cause. So that will be the pillar of treatment in any case of hepatic encephalopathy. Along with that, we need to initiate empirical therapy. What are the empirical therapy? I'll come across again. Okay, based on these events, when you see this patient, you will have, because of your clinical examination, you would have already classified and graded the patient. If you feel that the patient is in grade 3, grade 4, admit the patient to an ICU. If you feel that the patient is a case of a covert type of hepatic NCAF or grade 1, you can still admit the patient in the ward and follow up with routine management, which is getting the gut clearance with oral lactulose and rifaximin, etc. So if the patient is comatose or if the GCS is less than 7, it warrants us to secure the airway. And because the GCS is low, get the whole metabolic as well as the coagulation parameters checked. Look if the patient is actively bleeding, look at the clinical hemodynamic parameters, and then continue. So usually when you write this in such a way, it would be a comprehensive approach for any patient with metabolic encephalopathy. So you can use this algorithm in the first half for all your answers for metabolic encephalopathy. And then in the specific way, if it is hepatic, you can use this algorithm. If it is uremic, you can use something else. Okay, based on these things, you can change your answer. So this is something which was recently asked. So if you write this, it will save your time, and it is a pictorial depiction which gets you more marks. So understanding the need for management. So I spoke about the pathophysiology. So if you've understood the pathophysiology, we all know that the major culprit here is ammonia overproduction, or the ammonia metabolism being hampered, and that can cause a lot of issues. So there have been various treatment strategies which are directed towards this. So there are a few things to address the neuromodulation, that is benzodiazepine antagonist. There is thought about getting systemic circulation shunt closed, which again reduces the ammonia delivery to the brain. Use of non-observable antibiotics like rifaximin, use of albumin, use of Mars, use of nutrition like L-ornithine, L-aspartate, branched-chain amino acids, and the clearance of ammonia from the gut, that is lactulose, rifaximin, and probiotics. So these have been there since more than 3 to 4 decades. But still there is no solid evidence. So let's go check each of them accordingly. So whenever we feel that the patient presents to us with mood and personality changes, behavior and impulse control issues, memory and concentrative thinking, consciousness and lucidity or sleep cycle alterations, coordination malfunction, loss of autonomy. So along with this, if the patient is a diagnosed case of liver failure, go ahead, get his West Haven classification checked. You just see how bad the patient is, and then send for other routine investigations. There is no laboratory investigation which can help you in the diagnosis of hepatic NCEF. It can only help you to identify precipitating factors. Measuring ammonia levels might seem to be attractive, but there is no role which is being implicated still. The ammonia which crosses the blood-brain barrier does not reflect the ammonia which you are drawing. So even if you're sending a serum sample, they say arterial ammonia, venous ammonia, it grossly doesn't matter, because the level which you need to check is the cerebral circulation, and that. So invasive test for just getting the role of, getting the value of ammonia doesn't have any major role. So can ammonia be omitted with all of this? So the best evidence for the relationship between ammonia and hepatic encephalopathy in the context of liver failure, they say that a value of more than 100 millimoles per liter is, identifies the patient as a high risk patient of developing hepatic enceph. But they have also found out that a cutoff value of more than 80 millimoles per liter was associated with a 28-day mortality, higher 28-day mortality. So if not for initiating treatment, it can be used as a prognosticator or a yardstick to assess the worsening or the improvement of a patient, but never for initiating a gross therapy. So what does the EEG in hepatic encephalopathy look like? So usually in the grade 0 of hepatic encephalopathy, there are no EEG changes. Subclinical, none. Grade 1, 2, and 3 usually shows this triphasic. This is the triphasic. You can see 3 components in this, right? So usually there's one upstroke, downstroke, and then one followed by another upstroke, which usually see in a 5 Hertz pattern in hepatic encephalopathy. So usually in grade flow, what happens, it usually slows off delta and slow wave activity. So the triphasic pattern is lost in grade 4 hepatic encephalopathy. So if you see you see a triphasic pattern initially, and on re-examination, it becomes a delta wave. The rings, the patient should be, monitored closely, probably needs a neuroimaging, probably need to check all the other parameters. Probably the cerebral edema has increased, or the patient is herniating, or you need to act quickly in such patients. So when do we do neuroimaging? So we saw all these parameters. So the prevalence of intracranial hemorrhage in acute and chronic liver failure was higher than the decompensated cirrhosis. So whenever you have a patient who comes to you with ACLF, always have a lower threshold to get a neuroimage if the patient deteriorates in the ICU. If you see that the hepatic NCAF grade is increasing, or if you see that the patient is having hemodynamic instability, or if you have any pupillary abnormalities which you see, which is the earliest sign. So pupillary examination is very important in a patient with hepatic encephalopathy. So if you see any of these changes, it would warrant you to get a neuroimaging. An obtunded ACLF patient without abrupt deterioration in synthetic liver functions was relatively young. These are the patients who usually tend to develop rapidly progressive cerebral edema and herniation. So what are the goals of care and management of hepatic encephalopathy in a chronic liver disease patient? So you identify the hepatic encephalopathy, whether it is because of decompensated cirrhosis or it is because of ACLF. ACLF, you need to know that it is a very rapidly progressing with higher mortality. So have a lower threshold and keep closer watch. Look for the precipitating factors and treat them accordingly. Initiation of the first year therapeutic strategy specific to hepatic encephalopathy. I will explain. Like in traumatic brain injury, hepatic encephalopathy also has trial-based approach, which I will be discussing in the further slides. Okay. So the first trial usually would be to initiate lactulose or initiate rifaximin. These are the things which are usually seen in first year approaches. Okay. So basically, it aims at reducing intestinal ammonia production and nutritional and micronutrient supplementation in a cachectic patient or a poorly nourished patient. So the initiation of second tier therapeutic strategies is usually plasma ammonia lowering devices like your MAS, albumin dialysis, etc., or doing a CRRT, eliminating spontaneous portosystemic shunts, like you do an embolization of such shunts. Alternative pathway therapies. There are a lot of other newer things coming up in the medicine. So you can try those, and neurotransmitter blockade like flumizine. So these are the things which are broadly classified. Diet, cathartics, and antibiotics, which are starters. Then you go with L-ornithine, zinc, glycerol, phenylbutyrate, and L-carnitine, and hydroxyzine. So with all of this, usually there is not much of evidence which you have to see. I'll come to the evidence in the later slides. So how do these act? Okay. So we as of now know there is grade 1 evidence or the strong recommendation for two things, that is lactulose and rifaximin. So the mechanism of action is osmotic laxative, acidification of the colon, and it causes decrease in urease producing bacteria and decrease ammonia production and absorption. The benefits of the same would be it improves cognitive function. It is usually the one which is most extensively studied. It has been shown to decrease the progression to overt hepatic encephalopathy. So the mainstay of hepatic encephalopathy treatment is lactulose. Even having said that, you have to always ask three major questions when you're treating a patient with lactulose. How much lactulose? Usually 20 to 30 ml in the first 2 to 3 hours. The target would be to get a soft bowel movement. You should usually target 2 to 3 bowel movements in the first day itself. So unless you get that 2 to 3 soft bowel movements, you can still keep repeating lactulose around 20 to 30 ml every hourly. So once you get in first bowel movement, it shouldn't be continued till the stage where the patient has severe diarrhea and ends up being hypovolemic. That again would be a trigger causing worsening of hepatic function, leading to hepatic encephalopathy. So you need to be very careful while treating a patient with lactulose for the management of hepatic encephalopathy. With all of this, it's not shown any mortality benefit. What is the use of rifaximin? Mechanism is usually it reduces urea producing bacteria and increases the ammonia production. The benefit is it also causes improved cognitive functions and reduces hepatic encephalopathy related hospitalization. The most important thing with rifaximin, which has been studied, is it modulates the gut flora. The other side of it is usually rifaximin, 550 BD. That is quite expensive if you calculate for a patient who is going to be in the ICU. So having said that, it has shown to give strong recommendations in the recent guidelines to prevent worsening of hepatic encephalopathy. Branch chain amino acids, LOLA, glycerol, phenylbutyrate, zinc, and FMT, these do not have evidence still, but they are used in management of hepatic encephalopathy. Branch chain amino acids usually promote synthesis of glutamin from ammonia in skeletal muscles. So there is an organ pathway or crosstalk which happens. Glutamine synthase is still present in the skeletal muscles. So what can be done is glutamate gets converted. Glutamine gets utilized, and ammonia is formed. But this can get saturated when the amount of ammonia gets higher in the body. So this is not for long-term patient, especially what the FDA approves for right now is BCAA is used only for outpatient prophylaxis, but not for patients with ICU settings. There is no study or evidence for ICU patients. So if you see, there is no effect on overall mortality as well. L-ornithine L-aspartate is an ammonia scavenger. It is usually shown to reduce the progression to overt hepatic encephalopathy, but this again has not proven any efficacious use. Glycerol phenylbutyrate has shown to increase excretion of glutamin. Increased excretion causes the occurrence span, that is from one episode of hepatic encephalopathy to the second episode, the time has been shown to be prolonged. That means to say the patient has a hepatic encephalopathy free period for a longer time. So it hasn't shown to be anywhere superior to rifaximin, but there are still many head-on trials that needs to be done to prove that glycerol phenylbutyrate is better than rifaximin. Role of zinc has been recently studied in many papers, and RCTs have also been done. What it does usually is in patients with zinc deficiency, the urea cycle utilization of ammonia gets hampered. So if you supplement this zinc, the utilization of ammonia is improved, and then hyperammonemia is reduced. This is the basic understanding of mechanism. But the end result, what they are seeing is only cognitive improvement, and no major changes have been seen in these patients. So the use of zinc, especially in a chronically ill patient, would not cause any harm in ICU patient, but still no greater evidence to tell that it has to be mandatory or strongly recommended in patients with ICU setting. FMT or fecal microbiota transplant is still a huge topic. There is no great evidence for this. Basically, hyperammonemia has to be reduced. The colonic bacterial microbiome has to be altered. This is the whole idea of FMT. But there are a lot of other prerequisites that has to be done, and to get this across, it's still a Herculean task. So basically, for these reasons, it is still not routinely used. Okay, it's currently under investigation. The major thing what they're looking at is the improvement in hepatic encephalopathy. Mortality benefit anyways is a long shot still in FMT. So coming to the tire-based approach, which I previously mentioned, the tire one usually includes lactulose, rifaximin, and nutritional supplementation. Nutritional supplementation, we already spoke about zinc. The most important thing which you need to remember is the use of L-carnitine. L-carnitine has been shown to be beneficial, and it is FDA approved in patients with chronic malnutrition, recurrent admissions to the ICU with hepatic encephalopathy, but first admission to the ICU with hepatic encaph or grossly deranged liver parameters, still not proven enough. But still, there is role for L-carnitine. Branched-chain amino acids, I've told you, doesn't cause any benefit in ICU patients. The tier 2 ones are in patients who have not improved on tier 1, that is lactulose, rifaximin, nutritional supplementation. Tier 2, there are again two things, advanced and primary. The primary is usually the use of CRRT, MARS, therapeutic hypothermia, LOLA, or use of flumazenil. So these things are usually tried in patients more or less in acute liver failure developing hepatic encephalopathy. There is no gross indication for the use of tier 2 management in hepatic encephalopathy due to chronic liver disease. So in tier 2 advanced, we have embolization of shunts and liver transplant. So you need to remember tier 2 basically when I discuss about hepatic encephalopathy in acute liver failure. So coming to summing up all the evidence which is there for the management of hepatic encephalopathy. So the EASL, that is the European Association of Study of Liver, has recently published a guideline in 2022 September for the management of hepatic encephalopathy. So basically what has happened is there are a lot of recommendations, but the level of evidence is still very poor. So I don't want to overburden you. There are around 32 recommendations which have been given. I'm just going to go to the most important one. So what we need to remember for starters, for people who still want to understand this, usually when we tell about grade of recommendations, either it is strong or weak or open. So the ones which are strong is usually backed with good evidence, usually with meta-analysis on RCT. The weak ones usually would be expert opinion or case-based scenarios. So lactulose, as you see, level of evidence is 1 and has a strong recommendation to as a secondary prophylaxis after the first episode of overt HE. As I told you previously, you should titrate it to obtain around 2 to 3 power moments per day. So if the patient presents with a GI bleed, rapid removal of blood from the GI tract, that is the precipitant hepatic encephalopathy management, is something that is also carrying a level of evidence 1 with strong recommendation. Rifaximin as an adjunct to lactulose is also recommended in secondary prophylaxis following more than 1 episode of overt hepatic encephalopathy within 6 months of the first episode. This is also having level of evidence 2 and a strong recommendation. So whenever you see patients coming back again and again, there's always better to start this rifaximin. So patients with hepatic encephalopathy, precipitating factors should be sought and managed. That is again level of evidence 2 and strong recommendation. Zinc supplementation is not recommended. So that is a strong recommendation. Patients with cirrhosis, previous episodes of overt hepatic encephalopathy, rifaximin can be considered for prophylaxis of hepatic encephalopathy prior to a non-urgent TIPS placement. So a standalone or a combination with lactulose or a non-absorbable disaccharide can be considered. This again is a level of evidence 2 and a strong recommendation. So what I mean by level of recommendation, I mean evidence-based here would be a systematic review or RCTs or better evidence is seen in these things. So what you need to remember is use of lactulose, rifaximin, no role of zinc as of now, no role of BCA as of now for ICU patients. L-carnitine, if the patient is malnourished, you can still think. LOLA, if the patient is coming back again and again with multiple things, you can still think. Okay. So this is about patients. So far, we have covered hepatic encephalopathy in CLD. So here onwards, we're going to go for hepatic encephalopathy in acute liver failure, or as by classification of causes, it is hepatic encephalopathy due to a reason. That is, it can be because of acute liver failure due to a drug, toxin, etc. So how do you go ahead with these things? So usually we want to prevent this patient from developing a type C hepatic encephalopathy. That is the whole idea. Okay, so whenever they come with type A hepatic encephalopathy, you need to clinically assess the patient, get a Westhaven grading, check for the organ failure, probably use asterixis and GCS. So with the previous pathophysiology picture in mind, this actually gives you a complete understanding of hepatic encephalopathy and ALF. So if you recollect from previous slide, I have told you that the worsening of hepatic encephalopathy in ALF is faster. So what happens here is we see that the cytotoxic edema or the cerebral edema which happens in ALF is faster. That is because there is a sudden load on the liver for metabolizing ammonia, which is not able to do, and ammonia just crosses the blood-brain barrier and enters. If you can look at the left side of the screen, you see what happens here is ammonia goes and it gets synthesized by glutamine synthase into glutamine, and that glutamine is osmotically active. So what happens when it becomes overly loaded in the cell, that is usually the astrocyte, it causes cell swelling, or it causes cytotoxic edema. That is usually because glutamine triggers the upregulation of aquaporin 4 channel, and water just starts entering into the cell. Along with this, ammonia also causes uptake of a lot of neurotransmitters, usually tryptophan, tyrosine. They are all precursors for excitatory neurotransmitters. Because of this accumulation, dopamine, norepinephrine, and serotonin goes up, and you will see a surge response happening in patients with ALF. If you come and see the same glutamine, actually, again, the presence of glutaminase in the mitochondria of the same cell converts it back to ammonia, which again causes a lot of reactive oxygen species, causing cell, swelling. So what happens again is it increases the conversion from pyruvate to lactate, inhibits glutamate uptake, activates peripheral types of benzodiazepine receptors. This is where flumazenil has been indicated for the use. So why this happens is the GABAergic expression usually gets activated. The GABAergic expression usually would be, carried forward by the GLT1 receptor, that is the glutamate. The presynaptic membrane usually contains a lot of the synaptic cleft, in fact, actually gets accumulated with a lot of glutamate, which is not being synthesized, and this causes neuroexcitatory phenomenon. Neuroexcitatory phenomenon can usually start with restlessness, agitation, and it can go to a worse spectrum of seizures. The consequences of progressing to a grade 4 hepatic encephalopathy is significantly worse in acute liver failure. Usually, it is due to increase in intracranial hypertension and resulting in herniation. It is imperative that early determination of acuity in liver failure needs to be addressed, closely monitored, and you need to transfer the patient as soon as possible if you feel that the patient is deteriorating rapidly to a regional liver transplant program, because these patients do well. Okay. Acute liver failure patients can rapidly decline and usually end up with distributive shock, leading to a multi-organ failure. So what are the neurochecks usually you have to do in ALF? Monitoring pupillary function, I've told you previously as well, it is very, very important. This might be one of the first things which we can see, especially when the patient drops from Westhaven 1 or 2 to 3, and then from 3 gradually to 4. If you feel that the pupillary reaction is not good, then that is significance of increased cerebral edema, which is usually causing some sort of compression. Usually uncal compression is seen, and it causes stretching of the ciliary fibrils of the third cranial nerve, which leads to the loss of pupillary function. So whenever the patient develops from grade 3, grade 2, grade 4, always rule out the possibility of seizures. It's not bad to get a continuous EEG if your institute has one. Intermittent EEG should also suffice. If your patient is there and from morning you see that the patient is deteriorated, get an EEG, at least a short course. At least you will know what type of EEG it is, whether it is triphasic or delta waves of presence. If you see a triphasic wave, still you can give some osmotic therapies and get the cerebral edema down. If the patient is showing delta activity, you need to activate the liver transplant team in such cases, with neuroprotective measurements being in check, especially in ALF patients. Risk factors for developing ICH and ALF: plasma ammonia level usually more than 150 to 200 millimoles per liter is associated with development of intracranial hypertension. But what has been said is this level is not fully, optimal. There are patients who develop intracranial hypertension, especially with ammonia less than 146 as well. There is disproportionately, higher degree of extracerebral severity of organ function and ammonia if you see the SOFA score. So we cannot relate ammonia to, cause of worsening organ failure. So that is also something that we need to keep in mind. We need to always remember the other precipitants, which are usually the deterrents in acute liver failure, like hyponatremia, volume overload, severe hypercarbia, acidosis, and ventilator dysynchrony. These can worsen the patient, and maybe the patient will cone if we don't treat. So when do we do a brain imaging and what does it show? Usually what has been said is serial imaging is something that is necessary, because if you see CT does not give you much of an information. Probably it's an overt cerebral edema, you will just see overt cerebral edema. But if you have a baseline CT and you compare the CT over a progress of time, that is when you will be able to understand, yes, the cerebral edema has increased or not. MRI is usually done for patients who are very stable. If you can do it, what they suggest is the mandatory thing is there has to be by a person who can manage the airway, and it has to be a trained intensivist who goes for the MRI scan. So what does MRI do? It helps us exclude CNS infection, brainstem stroke, Wernicke encephalopathy, or metronidazole encephalopathy, and central pontine myelinolysis. CT or brain imaging should only be pursued if there is a high index of suspicion. So what you see here is there are newer findings which have been mentioned. Okay, well, there is something called as a limited cortical restriction and a diffuse cortical restriction imaging, which we see. So if you see the image here, it shows the cingulate gyrus along with the insular cortex and thalamus being involved, which is seen in a limited setting. This is earlier changes. This can progress into diffuse changes in the later stages. So this is what you usually see in an MRI if you do it. CT also can pick up, but yes, you should have a good radiologist and a good machine probably. Then you might be able to pick up these changes. So management of hepatic encephalopathy in ALF, identify and treat the cause. Risk factors have to be addressed. Elective neuromonitoring is necessary. Use invasive, non-invasive, anything. But there has been no greater evidence to prove that invasive is better over non-invasive, as in the case of traumatic brain injury. Non-invasive usually would be better because these patients have coagulopathy. These patients are prone to have infections, so better to do non-invasive. There is no gross, studies or big studies which have been done to show which is better over the other. There have been multiple. Most common, which was checked previously and time immemorial, is the GCS with West Haven criteria. Along with that, pupillary examination, transcranial Doppler, jugular bulb oximetry, and ONST has been used. But there is no evidence to say that these are validated checks and one is better over the other. But having said this, do a monitoring, keep a documentation so that we know, especially in case of ALF, especially these patients are going to have some medical legal implications. So these things would help us corroborate better and help us manage these patients well as well. Initiate neuroprotective strategies is very, very important in patients with ALF. Basics of neuroprotective strategies similar to patients with CNS issues like TBI, head elevation to 30 to 45 degrees, osmotherapy. When you choose osmotherapy, usually hypertonic saline is better than mannitol, because whenever you think of usually putting this patient on a CRRT, if the patient has dysnatremia, probably hypo or hyper, the plasma light has to be adjusted. Otherwise, rapid swings in sodium can again cause osmotic demyelination or worsening hepatic NCAF in these patients. So this is something of a small nuance that we need to remember whenever we are thinking of osmotherapy in patients with acute liver failure. Plasma ammonia lowering strategies, usually when I've spoken earlier, that is tier 2 approaches, initiation of CRRT, TTM, avoid hypokalemia, metabolic alkalosis, and other plasma lowering strategies. Rescue maneuvers usually maintain hemodynamics. If the patient is having seizures, probably use phenytoin, go up till phenobarb coma. Hypertonic saline and mannitol for osmotherapy. Neuromuscular blockade is usually better if the patient is having a sustained refractory raised ICP of usually more than 20 millimeters of mercury. When do we de-escalate? So as of now, de-escalation, usually when we see there is better recovery of the patient, EEG shows absence, seizures, and sodium levels are normal, metabolic profile is clear, then we can think of de-escalating these patients to put them on tier 1 approaches and then stop them accordingly. Seizures that can get unnoticed because the patients will be in a comatose state. So whenever you have a patient with grade 4 hepatic NKF, get these patients sorted with continuous EEG monitoring. If you don't have a continuous EEG monitoring, at least get EEG once a day to just know whenever it is possible. Gold standard continuous EEG. Phenytoin was shown to reduce breakthrough seizures, but prophylactic use of anti-epileptics was shown to not prove any benefit. So usually the drug of choice is phenytoin. You can even use levetiracetam as an alternate therapy. So what is the role of CRRT in ALF? Continuous renal replacement therapy and survival. Usually this was a major debate till recently, when to initiate, will it help or not, and all of this. So CRRT, as of now, this is one of the recent meta-analysis. If you can see, it is just 2 to 3 months ago in June 2024 that it was published. What it found was ammonia is a key driver of cerebral edema, and that is the harbinger of all the chaos that leads after that. So continuous renal replacement therapy, if you see that the patient is in ALF and worsening rapidly, has shown to prove benefit. Okay, but whenever you have these patients going on to CRRT, it would be wiser to get a neuroimaging prior to this, because if at all there is an eventuality which happens later on, like bleeding, etc., because CRRT involves a certain amount of anticoagulation, etc. So you should not have any medical legal implications for blaming the CRRT to cause the bleed rather than the acute liver failure. So this is some practical tips that we have ourselves found as well, and we luckily had done that. So this is something that I wanted to highlight again. So whenever you're thinking of initiating any extracorporeal therapy in patients with ALF, get a baseline neuroimaging. CT is also enough, at least rule out a bleed. Then go ahead with your implementation of CRRT or MARS, etc. MARS has been shown to give some benefit, especially because it uses albumin dialysis. So whenever you're using albumin dialysis, it usually helps in removal of protein-bound toxins, basically bilirubin, which is usually higher in load and causing a lot of stress on the CNS. So along with this, MARS also helps in removing few water-soluble toxins as well. So the overall FDA approval for MARS is only in ALF-induced hepatic encephalopathy. Use of MARS for CLD is not there. There is no indication from FDA as well. So there is no indication from FDA. There is no data available for CLD causing hepatic encephalopathy. So summarizing the whole talk, the take-home messages: you should differentiate hepatic encephalopathy seen both in ALF and CLD. Management is based on the severity and speed of deterioration. Largely, neurological changes are seen in early ALF and may go unnoticed in CLD. Newer drugs need validation still. Lactulose, rifaximin, still, yes, there is benefit. Other drugs, still, you need to understand, there is no greater evidence in ICU patients, especially. Decreasing ammonia load seems to be backed by good evidence in reducing morbidity, even though it is not shown to have any mortality benefit. So one thing there is no doubt about is there is no single therapy which has shown mortality benefit in management of hepatic encephalopathy. So in ALF, acute deterioration in sensorium and worsening metabolic profile warrants early CRRT based on the recent meta-analysis. Thank you. Questions, I'll take it in the box and I'll answer accordingly because of lack of time. I think so the next speaker is already waiting. So I'll be happy to answer your questions later on. I think so the next speaker can take over.
Yes, sir. I'll start now. Yeah.
Thank you.